Hey guys, this is FixerMed. Welcome back to my high-yield anatomy review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. In this series, I will be covering a broad overview of the discipline of anatomy across various organ blocks for these examinations. This will be part 39 of my multi-part video series of doing so. Without any further delay, let's go ahead and get started on today's content. Let's start off by taking a look at nephrolithiasis. Renal calculi, or kidney stones, are solid concretions formed from dissolved urinary minerals. The most common types are calcium oxalate stones, followed by calcium phosphate stones. Many kidney stones are small enough to pass through the urine stream without causing symptoms. However, stones that grow to a sufficient size, at least 2 to 3 millimeters, can obstruct the ureter, leading to renal colic. Let's next take a look at Staghorn Calculi. Staghorn calculi are renal stones that develop in the pelvicoileal system and can form a branching structure resembling stag antlers in advanced cases. These stones are composed of magnesium ammonium phosphate and form in urine with an abnormally high pH, above 7.2. The elevated pH typically results from recurrent urinary tract infections caused by microorganisms like Proteus mirabilis. Let's next take a look at renal veins. The right renal vein is much shorter than the left. Both veins lie anterior to their corresponding arteries in the hilum of the kidneys. The longer left renal vein is joined by the left suprarenal and left gonadal, testicular or ovarian veins before reaching the inferior vena cava, also known as the IVC. The left renal vein crosses anterior to the aorta, just inferior to the origin of the superior mesenteric artery, also known as the SMA. Alright guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A 35-year-old man presents to the emergency department with sudden onset of severe left flank pain radiating to the groin. He describes the pain as sharp and colicky. He has had several episodes of nausea and vomiting. Physical examination reveals left costovertebral angle tenderness. A non-contrast CT scan of the abdomen reveals a 4 mm calculus in the left ureter. Which of the following is the most likely composition of this renal calculus? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is B, calcium oxalate. Calcium oxalate stones are the most common type of kidney stones. They form when urine is supersaturated with calcium and oxalate. The patient's symptoms of severe colicky flank pain and the identification of a ureteral stone on imaging are typical presentations of nephrolithiasis, with calcium oxalate being the most prevalent type. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Uric acid stones are less common and typically associated with acidic urine, pH lower than 5.5, often in patients with conditions like gout or high purine intake. They are not as prevalent as calcium oxalate stones. C. Struvite stones, also known as infection stones, form in alkaline urine, pH greater than 7.2, due to recurrent urinary tract infections with urease-producing bacteria, such as Proteus mirabilis. They often form Staghorn calculi, which are larger and have a branching structure. D. Cystine stones are rare and occur in individuals with cystinuria, a genetic disorder that affects the renal reabsorption of cystine. These stones are usually detected in younger patients and are not the most common type of stone. E. Calcium phosphate stones are less common than calcium oxalate stones. They typically form in alkaline urine and can be associated with conditions causing hypercalciuria or renal tubular acidosis. All right, now that we have covered this question, let's move on to look at the next question. A 52-year-old woman presents with recurrent episodes of fever, chills, and right flank pain. She reports frequent urinary tract infections over the past year. Physical examination reveals right costovertebral angle tenderness. A non-contrast CT scan of the abdomen shows a large branching calculus in the right renal pelvis. Laboratory analysis of her urine reveals alkaline pH and the presence of Proteus mirabilis. Which of the following is the most likely composition of this renal calculus? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is C, struvite, magnesium ammonium phosphate. Struvite stones are typically associated with recurrent urinary tract infections caused by urease-producing bacteria such as Proteus mirabilis. These stones form an alkaline urine and can grow to fill the renal pelvis and colices, forming a staghorn shape, which matches the patient's clinical presentation and imaging findings. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Uric acid stones form in acidic urine, pH lower than 5.5, and are not associated with recurrent urinary tract infections or the staghorn shape. B. Calcium oxalate stones are the most common type of kidney stones, but do not typically form in the staghorn configuration, and are not specifically associated with urinary tract infections or alkaline urine. D. Cystine stones occur in patients with cystinuria, a genetic disorder, and are not associated with urinary tract infections. They typically present in younger individuals and do not have a staghorn shape. E. Calcium phosphate stones can form in alkaline urine, but are less commonly associated with recurrent urinary tract infections, and typically do not grow into the staghorn configuration. All right, now that we have covered this question, let's move on to look at the next question. A 45-year-old woman undergoes imaging studies for evaluation of hematuria. The imaging reveals an enlarged left kidney with a prominent left renal vein. Further examination shows that the left renal vein crosses anterior to the aorta and is joined by two additional veins before draining into the inferior vena cava, also known as IVC. Which of the following veins does not directly join the left renal vein? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is C, right renal vein. The right renal vein does not join the left renal vein. It drains directly into the inferior vena cava, IVC, on the right side. The left renal vein, however, receives blood from the left suprarenal vein, left gonadal vein, and other lumbar veins before it crosses anterior to the aorta to drain into the IVC. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. The left gonadal vein, testicular or ovarian, drains into the left renal vein, not directly into the IVC. B. The left suprarenal vein also drains into the left renal vein before it reaches the IVC. D. Lumbar veins can drain into the left renal vein, contributing to the venous drainage system of the kidney. E. The left adrenal vein, another term for the left suprarenal vein, drains into the left renal vein, which then crosses over to the IVC. All right, guys, that is all I have for this video today. If you like this type of content, be sure to leave a like and subscribe for more content like this in the future. Be sure to leave any questions, comments, or concerns down in the comment section below. This is FixerMed signing off. Be sure to have a great day, everyone, and good luck studying as always. Goodbye.